hygiene. I would like to introduce our two presenters to you. Firstly, Professor Sally Bloomfield is the chairman and member of the Scientific Advisory Board of International Scientific Forum on Home Hygiene. She's an acknowledged expert on home hygiene with more than 30 years experience in hygiene research and education. Welcome, Sally.
Thank you.
Our next, the second presenter is Dr. John Hines, who's Global Research, Development and Engineering Director for SC Johnson Professional. John has a wide experience in product design and development across several home and personal care categories. John is passionately focused on development and implementation of better professional hygiene solutions for healthcare, education, food, and many other institutional settings. And again, a welcome to you, John.
Thank you.
And no further ado, I will hand over to Sally.
Hello, have we got some slides?
Unmute.
Do we have some slides?
Yes, they're coming in a second, Sally.
Sally, it's
okay.
I'm doing it now. I'm not quite sure why it didn't work the first time of asking.
No problem.
Is that visible now?
That's lovely. Yes, thank you.
Okay.
Can we go through to my first slide? Yeah, lovely. Thank you very much. And thank you for inviting me to join this webinar. I think it's astonishing if we think back to the 1970s when experts in general were saying it's about time we close the book on infectious diseases. The age of infectious diseases is finished. And of course, what happened is that this heralded a rapid decline in investment in public hygiene and education and increasing complacency during the latter part of the 20th century. But what's happened is in the last 50 years, a number of fundamental changes have happened which have brought hygiene back up the health agenda, although I do have my doubts as to whether it has yet regained its rightful place in public health. Next slide. Thank you. One of the key changes I think we will we realize is the global pandemic, where obviously preparedness plans drawn up during the first 20 years of the 20th century clearly stated hygiene is the first line of defense to mitigate infection before other measures such as vaccines and so forth can be put in place. And in my opinion, I think we really didn't grasp this properly, and we were not really efficient in terms of the way we interacted with the public to help them to take on this vital role. The second change, key change, nothing related to vaccines, but equally to COVID, but equally important, is this problem of antimicrobial resistance, reducing the need for antibiotic prescribing and the spread of AMR strains is a vital pillar in tackling antimicrobial resistance. But again, if you look at the WHO, EU, US plans and the UK plans, what the UK plan clearly says is healthcare providers can only do so much. When it comes to infections in the community, the public have a huge role to play. But if you look at it, the plans at the moment mostly focus on healthcare facilities. And then the other significant change since the 1970s is the ever increasing population of people at increased risk of infection who are living in the community. Up to 1 in 5 people, maybe probably more. But what COVID has shown us is that hygiene is absolutely vital in terms of shielding these vulnerable groups through social distancing, face coverings, and so on. Next slide. In view of these changes, it has become apparent that what we really need is a fundamental rethink to develop hygiene in home and everyday life appropriate to the issues which we currently face. In the past, the focus has been on hygiene in the home and still is. And we know from the data that the majority of COVID infections were or are being transmitted in home settings by transmission from person to person. But what's become very apparent during COVID, what it's taught us is that public spaces play a key role in terms of transmitting infections between household units and thereby propagating the pandemic. What we have to understand, however, is that facility managers play a vital role in cleaning and facilitating good hygiene practice. And that's what we're going to be talking about today. But keeping a facility COVID secure depends very much on the hygiene behaviour of the public. It really is a shared responsibility. I'm going to talk about home settings, but what you'll come to see from John is that the principles of infection transmission are the same in both settings. Next slide, please. In order to deal with these changes, what the IFH has done since its inception in 1997 is to develop an approach to hygiene based on risk management, which has come to be known as targeted hygiene. This is based on the risk management approaches which were developed during the 1950s and have been used ever since to prevent contamination of foods and pharmaceuticals and so on during manufacture. This is a very different approach from hygiene as we saw it in the 20th century and still do to a certain extent, which has been largely concerned with keeping our homes clean, dirt being regarded as the main source of harmful microbes. The idea that if we keep our homes clean, that's the way to protect our family from infection. What COVID has shown us is that these public perceptions still tend to persist in the 20th century. Next slide, please. One of the things that shows us this is this problem of what has come to be known as hygiene theatre. These are the rituals which public health workers have tended to adopt, which make us feel safer, but don't do very much in terms of reducing risk. You can see from this picture the idea of scrubbing and fogging and deep cleaning of premises. Not only in theatres, in streets, in underground situations and so on, and in the UK, in gyms and restaurants and so on. There's no surfaces we won't sanitise, no machine we won't scrub to make our premises COVID secure. What this says is that there is a fundamental lack of understanding in public health that hygiene behaviour is the most important factor. You can make a place COVID secure, but as soon as people start entering that space, if any of them are infected, then they start passing those organisms around. So hygiene is an ongoing practice. It's not a situation. Next slide, please. So moving on to talk about targeted hygiene. What is targeted hygiene and why is it different? Next. Targeted hygiene depends on, first of all, understanding the chain of infection, or as we sometimes call it, the journey of the germ. And what this means, and I'm going to talk in regard to the home setting in this part of the presentation, is that we have to understand that there are certain sources of infection in our home. These are not places that are dirty. In our homes, it is people who are infected, or as we've seen with COVID, people who may be carrying infection, may not be ill, but are still infectious to other people. It also includes contaminated foods, mainly raw meat, poultry, fish, fruit and vegetables. And it could also be domestic animals. We know from the data that in some cases, pathogenic organisms carried by our domestic animals can be transferred to humans. In situations where there is an infected source in the home, then these organisms are being transmitted continuously into our environment and moved around our environment via surfaces and via the air. What's important is that we target just those surfaces which are likely to be responsible for us to be exposed to those organisms via our nose and our eyes, our mouth, via open wounds and so forth. The key to targeted hygiene is that it's about identifying what are those critical surfaces which cause us to become exposed and infected, and intervening at those points to prevent the spread. The bottom line being, if we are not exposed to harmful microbes, we cannot become infected. Next slide, please. I thought I would include a couple of examples just to make it clearer what we mean by this. And one of the easiest ones that I've chosen is the critical moment when we're preparing food, raw food. And this just shows something we're very familiar with, which is the preparation of raw chicken in our kitchen. And it's very easy to see then what are the critical control points. They are our hands, the utensils and the chopping board, all of which come into contact with the chicken, the cleaning cloth, which we use to wipe up any spills, and then any surfaces that we touch with our contaminated hands, such as tap handles and door handles, whilst we're carrying out the food preparation. What targeted hygiene means, sorry, can you just go back for a second? What targeted hygiene means is that immediately after we've prepared the raw food and it's gone into the cooking pot, that we clear up by cleaning and disinfection. What we've done then is we have entirely contained that risk, and it means that there is no need to then go on and clean and disinfect the whole of the kitchen. That is what targeted hygiene is all about. Next slide, please. The other example I wanted to share with you relates obviously to COVID, and is the key moment after we've been coughing or sneezing, nose blowing. And now we know also for COVID that it includes loud talking and singing. We know now from all of the data that's been investigated with regard to COVID, that the main source of transmission is via the air, either via droplets which travel short distances and can settle on surfaces and on our hands and be transmitted to other people, or more commonly, the tiny airborne particles which can travel for some distance and can be breathed in by other people. What we know, therefore, is that the main critical control points are the air, our hands and hand contact surfaces. So that sets up the messaging we hear from the government: social distancing, ventilation, masks, hands and contact surfaces. Next slide, please. But I think one of the key things that we have to recognize, and sometimes is not recognized, is that a key concept of targeted hygiene is that at each key moment, hygiene needs to be carried out at all the critical control points, not just one or other of them. And John and I decided that one of the easiest ways of explaining this is something called the Swiss cheese model. And if you look at these models, what you'll see is that the barriers of protection, which are the slices of cheese, there are a number of barriers of protection, but all of these barriers to protection are not 100% effective. They're less than 100% effective, and that's what the holes are about. What this means is, as we add each layer of protection, the reduction in risk increases so that we get a minimum risk to the spread of infection. And remember here, we're talking about a population of 65 million people in this country. So even if a barrier only contributes 1%, then that adds up to a lot of infections that have been prevented in the community. One slide. Oh, sorry, next slide. So I think that's what that's everything I have to say, except that I thought I should finish just by stressing why is targeted hygiene fundamentally different, because I think it's key to understanding what we're trying to do here. The standard equation for risk assessment is that risk equals hazard times exposure, i.e. within our homes or any setting, we can have a hazard, for example, a toxic chemical or microbial contamination. But that hazard only becomes a risk if we're exposed to that risk. What targeted hygiene is a risk management approach. And the risk assessment is based on, first of all, what's the probability of pathogens being present at key moments, but equally importantly, what is the probability of spread so that we are exposed? This is why it differs so much from 20th century hygiene, or what we call hygiene theatre, because here the risk assessment is based on the probability that the surfaces harbour germs, and the idea that if we can do a deep clean, we can get rid of those germs, we can make our environment safe. Hygiene, targeted hygiene, the Moments approach that John is going to talk about, is about preventing spread, not cleaning our environments. So thank you very much. And over to you, John, now to talk about the application of the targeted hygiene in public places.
Thank you very much, Sally. As always, extremely educational and extremely clear. Thank you very much for that background. So, as Sally says, we have been working with IFH for some time, and I think even before the pandemic, recognized that there's a gap in terms of a really clear, practical, scientifically robust hygiene best practice for public places. And by public places, I mean workplaces, schools, and general public settings that might include, for example, transport facilities, shopping centres, council offices, and so on. And I think it's interesting that you can classify those into sort of broadly two sets of places. You've got places like workplaces that the same group of people arrive at every day, or schools, for example, versus places where different people arrive every day. And of course, that sets different challenges in terms of how we should educate and communicate. And I'll come on to that later. What we didn't include in our scope for this work were the two types of public settings or of away from home settings where actually pretty decent hygiene guidance already does exist. And that would be healthcare settings where World Health Organization, WHO, has their 5 moments for hand hygiene in healthcare settings, as many of you will be aware, and also food preparation and food handling facilities, where again, very strict hygiene guidance is in place. So we're thinking more about those sort of general settings. Following the targeted hygiene principles, we identified 8 moments where we can see a key risk of infection, and therefore where hygiene can play a role in helping mitigate that risk of infection. And again, before I carry on, I would just re-emphasize what Sally's already said, which is that this is just one slice of the Swiss cheese, if you like. So we're not in any way suggesting that following the 8 moments means that we shouldn't wear masks, that we shouldn't socially distance where that's appropriate in pandemic circumstances. But certainly this is, you know, one of the slices of Swiss cheese. And I guess the other point I'd make here, and I think as we come out of the COVID pandemic, it's really important that we hang on to this, is that, of course, we all got coughs and colds before COVID, and we'll all get coughs and colds after COVID. And not every cough and not every cold, of course, is COVID, as any of you on the call today with kids going back to school will have probably recognized, as we certainly have in our house over the last couple of weeks. And the key point there is that, you know, while COVID may be a largely airborne infection where the slice of Swiss cheese attributable to hygiene may be a few percent of the total infection burden, there are many other diseases like norovirus, for example, or in fact good old influenza, where hand hygiene really plays a big role. And you've still got the Swiss cheese model operating, but what you might say is that the slice of cheese that we perform as hygiene practitioners maybe you might call it a thicker slice. I don't know, that's maybe stretching the model too far. So if you can advance to the next slide, please, Kathy. The key thing that we wanted to think about as we were working with Sally and IFH on the 8 moments is not only identifying those moments, and I will come back to them on a slide in a few moments, but also thinking about how do we implement the moments, thinking about, you know, what is it that we have to do in a facility or to help the facility really make this work. And that means addressing how do we design and equip buildings and public spaces with the right hygiene infrastructure. And that may be hygiene infrastructure within the washrooms, where we're very familiar with it. But increasingly, as we think in terms of pandemic and even post-pandemic hygiene, infrastructure outside the washrooms, making sure that hygiene is available at those key moments. And also, how do we educate and inform both the facility owners and facility managers and the practitioners, but also the facility users, which could, as I say, be employees, could be students, or could be the general public passing through an airport, on how and when and what are the key cues to practice hygiene. Recognizing that, especially in public spaces, and I think this is a key distinguishing feature from the home environment, in public spaces, there is that very clear shared responsibility. There's one group of people whose responsibility is to address essentially surface hygiene and to keep, to use targeted hygiene to keep the facility safe, and to make sure that hand hygiene is available as required. And then there's another group of people whose responsibility is to practice that hand hygiene largely. And there's sometimes a split, again, depending on the type of facility, but broadly speaking, it's really important to think about that shared responsibility. So in developing the program, we wanted to not only think about what are the moments, but also how can we help facilities practice those moments. So if you move to the next slide, please, Kathy. We developed an implementation program along these lines. And I think our recommendation would be that anyone managing a facility should really look at these 5 steps and should really look to engage with appropriate partners to assist with these 5 steps to try to get a program sustainably embedded. The first step is to evaluate the facility and identify where and what are the key moments. And I think that the key point here, and I'll come back to it because, again, I am going to talk about the moments themselves, is that, and Sally's already mentioned it, the difference here is we're not talking about key places. We're not talking about key environments. We're talking about moments. In other words, we're really thinking about behavior, and we're thinking about the flow and the movement of people through facilities, because it's that flow of people and it's that movement of people that creates the risk. And that's going to vary facility to facility. And I'll give a couple of examples in a moment of how that can vary. But the first thing is to evaluate and understand, in terms of your facility and in terms of the flow of people through that facility, what are the key moments, and when and where do those moments likely occur. And then for each of the key moments or clusters of moments that can be identified, figuring out what are the right solutions. And that's going to be a combination of making sure that hand hygiene can be practiced at those moments, but also making sure, where appropriate, that surface disinfection might be a critical intervention, and just figuring out what are the right combinations that work for your facility for those moments. And again, that's as much about the people flow as it is about the facility itself. The third step would be to make sure that, to really address education, and again, thinking about the shared responsibility, so that both the groups of people within that facility charged with delivering cleaning and hygiene, so the cleaning staff and the janitorial staff, are educated to understand which of the moments are they responsible for, and how to make sure that hand hygiene is provided. And also thinking through how do we educate the occupants of the facility. And that could be a combination of, for a workplace, for example, that could be formal education, that could be training, it could be embedding this within health and safety practices, within schools, that could be, part of classroom education. But for public facilities, it maybe is more around visual education. So it may be around posters, it may be around visual cues, reminders, a combination of factors, again, targeted tailored for the facility to make sure that people understand what's their job in this. And then the fourth step, obviously, is to implement that as a regular program, to make sure that there's maintenance and replenishment built into that program, both in terms of the products and services, but also in terms of the education. And through doing effectively the first 4 steps, to embed a sustainable program that helps create safe, healthy and sustainable environments away from home wherever possible. If you move on to the next slide, please, Kathy. So now eventually, after the long build-up, coming to the 8 moments. And what you'll notice here is and this is again just to re-emphasize that there's a lot of ing words, a lot of verbs, in other words, a lot of doing words as we learned in school. And again, that is because these moments are not places, they're not parts of a facility. They refer to people doing things. So touching common surfaces, coughing, sneezing, nose blowing, returning to and leaving your workstation, getting food prepared, entering and exiting the facility. Now, touch points in the restroom, okay, there's always an exception that proves the rule. Eating food, especially eating with fingers, and disposing of refuse. And again, what we've tried to do here, these moments are not complete, but our view is that they represent the majority of risks associated with people flow in typical non-healthcare, non-food preparation, non-professional food preparation environments. As I say, we have highlighted getting food prepared and eating food because, of course, that happens in offices, it happens in schools, it happens in workplaces. Disposing of refuse could be something that's performed by a professional refuse person in certain contexts, but it could also be something that's done by the office staff, by the teacher in the classroom. So we need to bear in mind those things. And what we've tried to do is identify those moments where it most likely is the case that a risk exists for passing on infection through either touching common surfaces or, in the case of coughing, sneezing, and nose blowing, directly expressing pathogens into the environment. So if you can move on to the next slide again, please, Kathy. I'll just give an example of how, for one moment, entering and exiting the facility, how, depending on the facility, different interventions can deliver targeted hygiene. So depending on the facility, and of course the key principle here is that what we've already got on our hands from the last environment we were in, we are at risk of bringing those things into a new environment whenever we enter a facility. And of course, as we exit a facility, whatever we picked up while we were there in that facility, again, whether it's an airport, shopping center, we then carry the risk of taking those germs into the next place we go. So entering and exiting facilities is a really good critical control point to make sure that, while we aren't necessarily trying to sterilize an entire environment, what we can do is make sure that the germ profile in one environment isn't transmitted to the next environment. And that's where the principle of this moment comes from. Now, depending on the nature of a given facility, there could be a number of different ways that we address that critical control point. It could be that we want to efficiently target cleaning and disinfection at that entry-exit point. And that might be a really useful thing to do if, for example, we're entering and exiting by touching a door, and if, for example, there are groups of people entering and exiting in, let's say, in batches, and that might be the case at a typical workplace, maybe where there's a clocking on time and a clocking off time. So if it's 9 o'clock to clock on and 5 o'clock to clock off, it might make really good sense to disinfect the door at 5 to 9 and at 5 past 9 and again at 5 to 5 and 5 past 5. On the other hand, if the facility is one that people are constantly coming in and out of, it's probably not efficient use of time, and it's probably bordering on hygiene theatre to have an operative standing by the door wiping the handle before and after every person moves through. It's probably much more efficient to place hand hygiene at the door and to make sure that as people move through the door on an ongoing basis, they're taking personal responsibility to clean their hands or to sanitize their hands before and after passing through the door. And therefore you address the same critical control point in a different way. And it might be, coming back to the first example, it might be that you still want to ask people to sanitize their hands, even though you're cleaning the door, because again, you're thinking in terms of what they may have carried through with them. So can you move on to the next slide, please, Kathy? Hopefully that gives an example of how different facilities may have the same moment, but a different intervention plan. And I just want to make the point here that, and again, in our case, we've designed a program, and again, it's not for me today to advertise SC Johnson Professional, but I think a good program would be one that not only provides products and services to address hygiene at the key moments, but also thinks in terms of how can we access the people who need to learn in different ways, again, depending on the environment, depending on the nature of the people who live and work in that environment. That might be videos, it could be brochures, it could be more educational papers that might be of interest to people with a certain expertise or with a certain knowledge and interest, or it could be really visual reminders. It could be posters to go on walls, it could be headers that can be directly placed on or near hand hygiene dispensers, just to remind people of what it is that's their responsibility. So it's really making sure that, as well as identifying the moments, as well as figuring out what the intervention is, again, to go back to step 3 of the implementation program, we also think about how do we best get this knowledge to the people that we need to get it to. Of course, that includes the cleaners themselves, the people who have a professional responsibility, but also the other users of any facility who share that responsibility to carry out hygiene. So again, facility by facility, audit by audit, it's about figuring out the moments, identifying the solutions, and identifying the most impactful and most appropriate educational pathways to get the job done. So if you can move on, I think this is my final slide, and it's just reiterating what we've hopefully already said by now. Targeted hygiene is about moments. It's not about places. It's about people movement through places. And it's about identifying where hygiene matters most and really making sure that we target those interventions at the points where we stand the best chance of mitigating the risk, and not really, I think if we go back to what Sally said earlier about hygiene theatre, imagine that you've got a hygiene gun with only a certain number of bullets. We don't want to waste bullets where those bullets don't have real value. So it's about targeting where we stand the best chance of making a difference to create safe and healthy facilities. And then it's about choosing the right products at the right moments in the right format. So again, I think depending on whether we've got an open foyer with a revolving door, or a door with a handle, or maybe even just an open space to walk through an entry and exit, that might help select what's the right way of approaching it. And should I have a wall mounted sanitizer or a podium mounted sanitizer, or do I need a bank of sanitizers? It's all about what's the flow of people, what's the right way of addressing it. The key thing here is that we're not trying to practice hygiene theatre. We're not trying to just give a show of reassurance. We're genuinely trying to help break the chain of infection, both in pandemic terms, but really importantly, post-pandemic, to try to get us back to a state that's safer and healthier than we were before, and recognizing that flu and norovirus and coughs and colds have always been around. And we've got a real opportunity now, I think, coming out of this situation to actually help create a healthier environment away from home than perhaps we had before. And the key element there is that it's a shared responsibility between the folks who set the environment up and the people who then use it. And then finally, just to remind on those implementation steps, evaluate your facility, figure out where the moments are and what the moments are, select the right interventions accordingly, figure out the right education programs, again, in the context of your facility and the people who use it, implement that, and carry on doing it, because it's not done. Well, it's never done. It's not done until it's done. We have to keep carrying on and keep finding new ways to refresh the story. So that's, I think, all that I've got to say today. I hope it was helpful. And again, I just want to thank CHSA for giving us the opportunity to communicate this program today. And I want to thank everyone for attending and for listening. And I want to thank Sally, of course, for the fantastic educational intro to help ground us all in the solid science that we're trying to implement. So that's it from me. I'll hand back to Lorcan, and hopefully we've got time for some questions. Thank you.